Hello and welcome to this Health Foundation webinar on applied health economics that's been designed specifically for the teams working with us in our Innovating for Improvement programme. I'm really delighted to be here today and delighted that so many of you have joined us. We have invited all of the round one teams who started their project setup in May of this year and the newly appointed teams from round two who are due to start in a couple of weeks at the beginning of November. Now, I'm Libby Keck and I'm a programme manager at the Health Foundation and I'll be chairing the session today. I've been working in healthcare for about 6 years, both at the Health Foundation and before then as a healthcare manager. And I've got very limited experience on the topic of economic analysis. I'm here today to learn just as much as you are. I'm really delighted now to introduce Mike Fern, who is a support consultant at Springfield Consultancy. Mike's been working in healthcare for over 30 years, originally as a nurse and operational manager, and more recently in service improvement and consultancy roles. And also very delighted that Rick Fordham is here from Norwich Medical School. Rick is a professor of applied health economics. He's been working in health economics for over 25 years and has got experience working in the NHS as a manager and in other health systems internationally. And Rick's aim is really to span the understanding between the academic and the professional realm, so you guys really are his target audience today. And our aim of this session is to start to demystify some of the language and the theory around how to approach an economic evaluation for your projects. Now, in terms of what's required of you from the Health Foundation, we aren't asking you all to do a formal economic evaluation for your projects, although we know some teams are choosing to do that. What we will ask of you, though, is for you to provide us with information about what the economic impact has been of your projects. And the reason we ask for this is because we know it's going to be really important information for getting your project sustained and spread within your organisation or more broadly. Now, in terms of the format today, Mike's going to start us off just giving you a bit of an overview really of the topic and why we thought it would be a good one to go through today. He'll then hand over to Rick, who's going to be spending about 20 minutes or so going through how you might approach an economic evaluation for your projects. Now, Rick has also really kindly prepared a handout for you all that goes through this topic in a bit more detail, and we'll be sending that out in the next couple of days. The remainder of the webinar will then be spent on questions, so I'd like to take this opportunity to just remind you to send any questions through to us throughout the time of this webinar. You can do it by typing them into the box that should appear at the bottom of your screen now. We've got a fantastic team here who'll be sending us through questions throughout the Q&A session towards the end of the day. And Rick will follow up on any questions that don't get answered within this hour slot. There's also a space for you to record any comments, so that will work as a live stream for anyone watching, so please do get involved and tell us how you're finding the session. I'll now hand you over to Mike, who's going to start us off.
Thanks, Libby. So why did we choose this topic? Why are we here? What's in it for you as participants? But probably more importantly, how does this benefit your project? And ultimately your patients by having a fuller understanding of the financial implications of your proposal and your intervention. So as Libby mentioned, I started off as a clinician. I'm still a clinician. So I understand that our professional identities are very much, we identify with the higher principles of healthcare, good clinical outcomes, and we tend to be a little bit more uncomfortable when talking about money and efficiency, and it can be viewed sometimes as a little bit unsavoury. Now, I also became an operational manager for many years, and I had no formal instruction in the mysteries of the NHS financial mechanisms. So who actually pays for it? How do the contracts work? What's involved in the service level agreement? What payments and costs are bundled up and what are unbundled? Where does tariff come in? New appointment follow up? All of these questions you really have to learn by talking to your colleagues. The first time I did a business case, it was quite a challenge, let alone doing an economic evaluation. So we want really to lift the veil on some of these questions of how you can construct in a sort of paint by numbers fashion a fuller understanding and economic evaluation. So I'm just going to briefly finish off with an anecdote. This concerns a site that we worked with. They were a particularly enthusiastic team. They had a wonderful project. They'd done some pilot work. They'd identified that there were some benefits to clinical outcomes and patients preferred it. In order to roll it out, they thought, well, let's go and see the chief exec and the finance director and really get their endorsement for this. So they did their 5-minute pitch. Chief exec looked a little bit impassive during that, and at the end there was a pregnant pause, after which the chief exec looked at the finance director and said to the team, well, actually, in order to give this my full backing, I really need to understand in more detail the financial implications of you doing this as opposed to what it is you're already doing. So how the costs and savings work out. So the enthusiastic, bright team, a little bit crestfallen initially, but they undertook to do what the chief exec asked alongside the rest of their evaluation. And I think the benefit of that was that it enabled them to sustain their project longer term in an environment where there are competing priorities for doing A as opposed to doing B. So how you go about that really will form the rest of this webinar, and that's why we've invited Professor Rick Fordham along to help us out. Thank you, Rick.
Thanks, Mike. Thanks, Livy. Yes, in fact, costs can be quite daunting, and hopefully we can disabuse some of the popular misconceptions about costs and make it more straightforward for you in terms of your projects going forward. And I'm pleased to say that you've got your grants and you're just starting out, but it can be a little bit daunting to think, how am I going to cost all of this? I've got no background, I've got no expertise necessarily, as Mike mentioned, in my training or any formal courses I've taken on economics, or let alone finance and costs. So I'm going to try today and make it as simple as I can for everybody. It isn't rocket science, but there are steps to follow, and economists have developed these over many years into a format that actually makes it very easy to unbundle and to begin to put the framework around how you go about this kind of method. So let's get started then. And I think the issue with costs is one that is in a sense over familiarity with them in our everyday lives. We see prices, we have charges, we have fees, all levied against us all of the time as individual consumers. We think we know what a cost is. It's something to do with price, isn't it? It's a price tag and such like. And to that sense, we're perhaps a little bit over familiar with what actually costs mean. So if we think about it more from how an economist might view a cost, that might begin to tease out exactly what we're looking for when it comes to your projects. So there are things that we would want to include, like prices, like charges, like fees, that will go into your costing. There's no doubt about that. There'll be things that we think about that are drawdowns on a budget. So I think a lot of health practitioners, health professionals, managers are all very familiar with their budgets. So there are things that are automatically put alongside your budget so that you can quite readily put those into a costing. And we'll come back to that in a moment. But those are the sort of things that ought to go back into your basket. In terms of actually the philosophy that health economists have always followed is that we are looking really at resources. What we want and need to know about anything that produces a good or service for a particular client group is what is it that needs to be bundled together in terms of inputs that will produce the desired or anticipated outcomes that we're trying to achieve. Now, for some, that will be mentally just for a new project like all of these that we're currently dealing with and you've got your grants for, would be just anything new. So for people, they might consider just any new cost or input into a program is in fact the cost of it. Because quite often people assume that what's already being provided, what's already there, is cost less. It doesn't have a cost, doesn't need to be costed, because it's being paid for after all anyway. So why should we throw that into the costing? Well, in fact, we need to do that, and we need to do that for a really important reason. And the reason for that is this notion of opportunity cost. If and when we cost out everything from the bottom up that needs to go into a program or a project in order to deliver it, then what we're actually saying intuitively is that those resources could be used in an alternative fashion, and it could be transferred somewhere else, given to another service or another program or another part of the healthcare system even, to produce something else, because you can only use resources finitely only once. So those resources could go into another project, and they could produce a different set of benefits, and those benefits would then be useful to the healthcare system. So what we need to know is what we're sacrificing when we're pulling together all of the resources for this particular project or a particular project, because it may be that if we don't count all those resources in, that we're actually overlooking this important notion of opportunity cost. So just beginning to scope out your costs is an important element of where we start in economics with the costing. And that's quite straightforward, but it's really, really important. You think about it and you decide what the scope or the perspective, sometimes as it's called, of your costing is going to be. Because that will determine which costs you include and which costs you don't include or you exclude. And that can have quite substantial implications in the future. So what we could do, we could start from the narrowest perspective of our scope of costs and say, it's only about my budget. I'm not interested in the implications or impacts it has for anybody else or anybody else's budget. I'm only interested in what it will impact on my particular hospital budget or clinical budget or departmental budget or whatever it might be. But we could pan that out to a much wider focus. The reason we do that is because, as I've said before, of the opportunity costs. If we exclude some of the costs that are necessary to deliver this program, and then we're actually not capturing all of the costs in that notion of opportunity. So we could extend it out to other parts of the healthcare system if we wanted to scope to the health and social care system too. We may be interested on the impact of this scheme or the project in the community or on the voluntary sector, all of whom may pick up costs. And finally, of course, and very importantly these days, a major consideration, I think, for a lot of programs is the impact that a project has on individual patients and their carers and indeed their families. Now, these may not be costs necessarily that impact on the healthcare budgets, but they are very essential to consider whether, in fact, they should be in or out. So, do think about those when you are starting to scope your costing. So, the 3 steps to costing that we recommend you take. This helps to break the problem down. Like any problem, if you break it down into smaller elements, bite-sized chunks, it's a lot easier to think about. The first element is identifying the inputs. So that's just generally making a list of the ingredients, like a recipe. If you're going to make a particular dish, you need to know what ingredients go into that particular dish. It's as simple as knowing the types of things that you'll require before you go shopping. The next step is actually measuring those inputs required. In other words, how much of those things do I need, in what proportions do I need them? That's simply is just analysing and identifying what those measurements are likely to be. They can be rough. They don't necessarily have to be that accurate, and indeed, sometimes we can't make them as accurate as we'd like them to be because we simply don't know what some of the cost implications are actually going to be before we start. Finally, we need to then say, we need to go shopping, if you like. We need to know what the prices of those inputs are going to be in those particular quantities. So we need to go and obtain those resources one way or another. And we then would be able to impute or place a value on those particular inputs. And we can do that by various means and various sources within healthcare, and sometimes go outside of healthcare in order to attribute value. And I'll come back to that later on. So let's go through the steps in a little bit more detail. So identification of costs. Now, you probably all have come across, or at some point in time, thought about or heard about the different types of costs that names that are bandied around for costs. We have things like fixed costs. They're the setup costs, if you like. They're the initial costs that you need to produce anything. So if we keep the analogy of the recipe going, they're the pots and the pans and the stove and perhaps the kitchen that you need to build in order to start producing even the first meal. So they're your fixed costs, and they can involve other types of cost as well, of course, like training. So you may need to bring existing skills into the mix. Variable costs, those are the costs that simply change as you change output. So as output increases, often costs increase in line with the number of units produced. So that could obviously, in a sense, be the number of patients treated or seen or assessed or screened or whatever your particular program involves. But those are variable costs, and they will change dependent on how many of those items you're processing. And then simply pulling those two elements together, the fixed and the variable costs, gives us the total cost. Now, there are some tricks with the total cost you need to do if, in fact, your costs don't always fall in the current period right now, and we may have to bring those back to, if they fall into the future, either costs or benefits need to be something called discounted, and they need to be brought back to present value. But we don't need to touch on that at the moment. That is a technical procedure. We have marginal costs, which are simply defined in economics as the cost of the next unit produced. So there may be 100 units being produced. Well, what's the cost of the 101st unit? Does it vary to the 100th unit? And we need to know that incremental cost. Now, we also have incremental costs, which are the difference between what we're doing now and what we'd like to do in the future, or what you're doing with your program. So it's the difference between program A and program B is an incremental cost. So what's being done in the past compared to what's done now or proposing to be done would be looking at the total cost in an incremental way. And I've mentioned discounting. So we can move on to some other costs you might like to consider. I won't dwell on any of these, but there are things called intangible costs. Those need to be taken into consideration because they may be important in your identification of the broad costs, even though you might not monetize them. But you may need to think about some of these, such as worry and anxiety placed on the patients, or a loss of confidence or reputational loss in some way by changing the status quo. And you have to think how important they're going to be when added into the actual monetary costs as to whether they'll make a difference. Measurement then is simply, as I've said, the identification of the quantities that are required of resources that need to go into your particular recipe for your particular project. The way that this is done is essentially in two ways. The first way being a top-down approach, which we call the allocation method, or the bottom-up approach, which is generally known as the audit method. And we often adopt a combination of both of these methods in actual real costing, because we can't assume an allocation method for every cost. For example, we can't assume that all costs will necessarily behave in one specialty like another specialty. So we actually have to go out and try and track some of those costs down in a kind of audit way using bottom-up costing. The different approaches, though, have different features. Top down is quite approximate, as you'd probably expect, but it's fast. Bottom up is exact and slow. So there's a kind of trade-off you need to make. But I think all costings that I've seen all involve both of these methods in order to come up with the total budget. So it's important to think about where you're going to go for your costs and how you're going to, whether they fall into those, which the allocation methods or which bottom-up methods you're going to use. There are measurement issues. We could talk about this for a long time, but just to touch on these, bear in mind that your studies, your projects will have an atypical period. They may have a lead-in period or a period of adaptation where people get going, get started, may not have recruited up to patients or staff up to the expected point where they are at full output. So think about what is a typical period in which to conduct your costing. Really important. Avoid lead-in periods would be my advice. Also, people get confused quite often in terms of when they're costing a project from a point of view of which costs are research costs and which costs are usual activity costs. So if you're employing people to collect data and monitor data that wouldn't necessarily be there in a normal situation, then that doesn't need to be part of the formal costing. Certainly a cost to the grant and certainly a financial reporting requirement of the Health Foundation, but it's not an economic cost because in a normal situation that probably wouldn't be there. Other issues, there are many, but try and get the advice from previous rounds that I've been involved with and previous other projects like this I've seen. Do try and get as local a cost picture as possible. It's not always possible to get that local granular feel to costs because they may not be available, but do try to start out with get your local specific costs if at all possible. They tend to be harder to get hold of because it's messier, but it does actually bear fruit in the long term. Otherwise, go to the internet, go to some global, international, even sources, but you'll find then there are problems with how you interpret those costs. Not every healthcare system is the same. Just a couple of words about rollout and extrapolation. Be careful if you're going to expand or upscale your project that you may not be making the same assumptions about doing a project for 50 people as you would be for 500 people. So those costs may not be linear. There may be step changes. There may be all sorts of twists and turns if you are anticipating a larger rollout or an extrapolation. And bear in mind, of course, there's diseconomies and economies of scale, I should say, economies of scale to everything. The bigger we get, generally, the cheaper things get. You reach a point where you also have diseconomies of scale, where things start to fall apart a little bit, and the bigger is not necessarily better. Other issues we can talk about the uncertainty around costs. As I said at the beginning, we don't necessarily know everything that's going to occur and in what quantities and how much you're going to end up paying for things. So there will be a margin of error in all costings, and it's best to build that in, and that can be built in by anticipating these kinds of variances and using sensitivity analyses to see what difference they might make. So look at the key cost drivers and say, are they going to go up or down by 5%, 10, 20%, and how might that make a difference to the budget? And that can be done at the end, so don't worry about doing it as you go along, as long as you make a note of what type of cost drivers you think are likely to be variable and important. So these are some of the common sources of variation. As I say, usually the key one in healthcare is case mix. People always anticipate a case mix which may be different and will drive costs in different ways, and the severity and so on of patients. But other things like staffing, the quality of standards you're setting, the expectations placed upon those quality standards, and so on. Also, location and the facilities may and can drive cost, depending whether you've got a distant location or you've got an an older style accommodation or something that may have some bearing on the costs. So then we get to valuation, and we say, well, how are we going to value the things we've identified? And that generally in healthcare breaks down to some very simple headings which you really can consider to be almost standard, such as staffing. Staffing, as perhaps most of us in healthcare know, account for around about 70 to 80% of costs. So immediately you've captured 70 or 80% of costs by just looking at the staffing issues. How much, what is your staff mix? How much is your staffing costing you? Is that stable? Is that unstable? Is it likely to change over time as people move in and out of the project? If you have a high-grade person is replaced by a lower-grade person, then you're kind of going to be costing something in the middle. Overheads, again, you need to consider. I'll come back to those in a minute. Capital, much the same. You may need to bring some new equipment into the program in order to deliver it. Think about that. Talk to an accountant about how you annuitize those capital costs, because they can be spread over a number of years in order to convert them into annual costs. And then there's all the consumable side. The main consumables, I think, in healthcare, you'll find in main acute areas anyway, perhaps not so much in chronic areas, will be drug costs. Those are standardly around about 12 to 15%. And other things like diagnostics and so on and so forth will also, testing and radiography and so on will also come in if it's important to your particular project, if indeed it is. But my top tip really would be to concentrate on those asterisks, items there I put on the slide with an asterisk, to actually just focus on those first. Bottom-up costing doesn't need to mean that you need to cost every swab or stick or elastoplast that's consumed, because it would be really counterproductive and not very cost effective to start with those small items and try and find a cost for those which are not going to alter the overall total. Where to look? There's a plethora of areas to find this sort of information out, but my advice would principally be start local if you can. Finance officers and finance directors generally have a very good overview of budgets generally, but I think managers know more about what goes into a program, what's required to make a program run and deliver it on the ground, and I think you need to speak to both. If you need to find out specific items that are really quite bespoke to your project, then you may consider going to logistics and procurement specialists that the NHS has around and drill down there. And finally, don't overlook the local budget holders. These are people actually running a service and actually have a responsibility for that particular budget. They may be clinicians, they may be managers or others. They will know and they will have seen over time how their costs are performing and what the composition of those costs are. A very good source of just generic unit costs is the Personal and Social Services Research Unit at the LSE and in Kent. A website address is available there. They put out every few years, I think the last one was in 2012-14, were the NHS unit costs book. It's a sort of a kind of ready reckoner of unit costs for just about everything that you can think of that moves in the NHS, and particularly staffing unit costs are very much included in there, and a very useful book to have. The other website will give you other references to useful links too. Be careful not to confuse costs with charges, because obviously the NHS providers charge for and get a tariff for providing services. Tariffs may not necessarily reflect the actual costs of production. So it's something that you don't necessarily want to substitute a tariff for a price, because it doesn't always mean an accurate cost. Identifying site savings, finally. We've talked a lot about costs. We've talked about how to bring them together. This is an element that we could talk about in a broader context in terms of return on investment. But what I think I would just like to leave you with today is that there are aspects of changing the way things are done in an innovative way that will have impact on other people's costs and other budgets. So think about that too, because here you can then net off or take off those particular savings off the budget that you are necessarily having to incur to deliver the programme. So maybe there are savings to be made, hopefully there will be, and you've identified some of those already, and you can simply then use those to reduce the overall cost impact. And on the slide there you'll see some of those examples of some of those, whether they're one-off savings in terms of things you can just simply stop, whether they're ongoing savings like lower maintenance or running costs of something. It may be savings to other budgets outside of your own particular realm. It could be savings in primary care, secondary or tertiary care, and so on. So have a look at some of those and consider whether you can offset some of those costs of your own programme against them. So in conclusion then, although you might think of finance being a fairly hard science and a fairly quantitative exercise, there is a lot of scope in costings for interpretation and the way that you might judge and interpret your costs of any programme. And I think this is best described by saying that costing is in fact both an art and a science. The art bit comes in because you need to understand the scope and identify the likely resources and the choice of techniques for actually measuring and valuing those resources. And all those are potentially amenable to discretion and choice. So in a sense it's a kind of sort of softer art to that. The science comes in and simply, as we know, all good science should measure things in exact quantities and understand how those quantities might vary given different scenarios. So we do need the hard science of quantification, but the interpretation and the scoping it has some elements of an art in it as well. So I think in conclusion, really, I'd just like to say that this is all if this is all very new to you, it may be timely to think about, do you need ongoing help? And the Health Foundation has that support in place. But if you need to go beyond this talk today, there are plenty of resources and health economists out there, probably somewhere in your region, who you could talk to and get some further details. But I think I'll leave it at that for the time being and hand back to Libby and Mike to take it on there from here. Thank you.
Fantastic. Thank you very much, Rick. Really interesting and enlightening presentation. I'm sure there's lots of food for thought for people out there who've been watching. And just as a reminder, if this has kind of raised any questions, please do send them through to us. This is your chance to ask our resident expert here for just 1 hour only. And just to kind of get us going, I just wondered if you had any advice really, Mike, for people who might be listening to this presentation and actually thinking, we may need more than just, a bit of theory. We probably need to speak to someone about our local situation. What would you advise?
There are some sites that have a university partner. There are some sites that come ready with a health economist as part of the team on the project, but I have to say they're probably less than 10%. So for those of you listening, don't worry if you haven't got a health economist on your team. That's perfectly normal. But because we've worked with 80 or so sites through the course of these innovation programs, we've come across sites that have had health economists, and we've got good examples of who's done the cost section of the final report, which I guess is part of people's sort of anxiety of how am I going to write this final section of our final report on costs. So we can share some of those with you, and we can also share the contact details of some of the health economists that they worked with, or the university partners that they worked with, who helped them construct that case. So I think talk to your support consultant first. We'll look at what sort of is the proportionality of how big or how small do you need to go with this, and we can recommend a course of action. But of course, health economists don't necessarily come for free. So there will be budget. Going back to finance, there's a cost. So it depends how much you've got within your grant funding, and also the context of what you're doing, what you need to do, I would say.
Brilliant, thank you. I've got a question for you, Rick, just to start us off nice and easy. When is a saving not a saving?
Well, I think savings, often people think that savings are something that have to be realisable, and so you can on paper make a saving, which doesn't necessarily result in a physical cash prize, if you like. It simply just gets reabsorbed back into the system. So for some people, that is the immediate hurdle when you say savings, Libby. They say, well, I can't see that and I can't get my hands on that. But there are ways of converting some of that saving, if you like, some of that spare capacity that is released into tangible benefits. Yeah.
I mean, we do have reports sometimes that says we reduced length of stay by 2.5 days for every patient. We treated 100 patients, and each bed day costs this. Therefore, we've saved that. And of course, the finance director will know, and you will know, that that comes really as a non-cash releasing. That's a productivity gain, because in the health sector, empty beds get filled up with more patients.
Precisely.
The only way you release cash is you close the 4-bedded bay, and the staffing complement or the establishment on the ward that works with that, or at greater scale, you close the whole ward and you transfer something in the community or outpatients, or better patient self-management, all of those things which are components of many health foundation projects, patient-centered care. But there is another complication which comes down to the way that the contracts work, and this was brought home to me in a project recently, whereby we had 2 groups of staff delivering follow-up outpatient care for patients with a long-term condition. So the nurses were on a block contract. So they made efficiencies. They saw some patients through FaceTime and Skype and web-based consulting. So they were able to see more patients because the web-based consultations were shorter. You have your programmed activity, you have your slot, you see, 10 more patients a week, 20 more patients a week. Nurses were on a block contract, so that made absolutely no difference to their income. The medics were on payment by results, or they were on a tariff. So each follow-up outpatient appointment, the tariff was £101. So on a simplistic level, you could say 20 more patients equals 2,000 and a bit income. But you need to talk to your managers, because you need to understand, well, have we got historical caps on activity? Do the commissioners can they afford this increased productivity at tariff because they're under great constraints as well. So understand your contract helps you understand whether it's cash releasing or not cash releasing. And maybe a concept that is used by Institute for Healthcare Improvement is this notion of light green dollars, which are the productivity savings, and dark green dollars. It's a very American way of putting it, but we've used it with projects really to just as a shorthand way to say, think about savings as to whether they're actual or more notional.
I think that's absolutely right, Mike, and I think there is some gradation of colour in the dollar in the sense that you could change some of that, say, cash releasing light green into sort of productivity gains, as you mentioned. If you can't actually reduce the service per se, or you wouldn't want to reduce, take those savings out of the service completely, because they're likely to be able to be of benefit somewhere else. But it's good to know that you can make a fairly hard and fast productivity gain, like you mentioned, through some of these sorts of initiatives.
And you talked earlier about sort of step changes. So you need an awful lot of units of saved time to equal one person, which then may release cost. And of course, we don't like to be in this business of making anybody redundant or closing any wards. But sometimes that's how it needs to be articulated in an economic case. When we think back to what you said, that 70% of costs, almost universally, is staffing, isn't it?
Yes.
If we look at a trust budget, it can be 100 million. 70 million of it will be staff, whichever trust you look at.
So I'll just go on to our next question. We've had one in, someone wanting to know about if they've got a project that's looking at kind of early intervention or prevention, how would you reliably calculate the savings if you're just kind of reducing risk and additional complications to a patient journey?
Okay, so that's quite an interesting one, and it's one that's close to my heart as also a public health practitioner. A lot of the times we're trying to improve the future health of a given population or client group, and you have to invest up front in the current to release those sort of savings, and in that sense you do need to know some hard and fast information and evidence, to have some evidence about the likely impact of that program. Now, this is mainly driven by epidemiological studies, it's mainly driven by clinical trial work. It might be evidence out there in the field from another area or another country even that says that, this screening program has prevented so many strokes or so many cases of heart disease or whatever it might be. And then so you would then, in a sense, what you'd want to do before you started off, before you even put your proposal in, really, is to say, I think this is going to avoid so many new cases of whatever it is.
So I wonder, Rick, whether what you have to do is demonstrate that you've reduced the risk factor of the avoidable harm. You don't, within your project, because of the time limitations of it, actually have to do the full trial yourself to say we have reduced so many amputations by stabilizing people's blood glucose levels. Let me point you to this meta-analysis of randomized control trials of how, if you can stabilize blood glucose levels, you will reduce X by Y and Z by A.
Yeah, that's really,
how much it costs.
That's a really important point. I mean, I often get asked this by public health practitioners, how they're going to do this, and it comes back to, you put your finger on it, I think, is the impact factor. How can you make a logical and a direct imputation from what risk factors you're going to reduce into the final outcome of the healthcare state that you're trying to avoid. So if you can reduce cholesterol, and it's demonstratable by a particular dietary intervention or even a pill, then you can say that the cholesterol will come down by such and such a percentage, or blood pressure, whatever it might be, and then you can then link that particular clinical outcome to a number of cases in a population that are likely to avoid that scenario happening to them. The only difference is that there is the time scale. Some interventions in terms of this sort of prevention activity will produce quite brisk returns and changes in people's behaviours and health status. Others will take a longer time to see that return. So again, there's a little bit of statistical and economic manipulation you need to do to those costs in order to make them comparable.
Great, thank you. Another question we've had in, someone asking about some of the terminology that's being used, so things like procurement and tariff, and these are words that aren't often used in a kind of health professional realm. So do you have any advice on a glossary of terms where people might actually start to understand the meaning of all these different words?
Do you know, I was looking at one the other day, but I can't remember where it was. There's some very good glossaries around, and I'm sure I can.
So we can add it onto your.
I can add it to my handout, but I've seen many that will give you sorts of things. But procurement is just really another word for purchasing, really, and the NHS has a whole procurement division, or so I'm told.
Great. A much kind of broader question now is, what do us as a panel think about the importance of quality adjusted life years, known as QALYs, which NICE are using at the moment, and cost utility ratios or something similar as part of a programme?
Do you like me to answer?
Yes, please.
There's two parts to that question. For those that are not familiar with cost utility ratios, let's just talk about utility. So utility is a kind of a measure that's been around and talked about in economics for hundreds of years. It means benefit or well-being, simply. Satisfaction perhaps, but it's a kind of measure of benefit, and we're all meant to be able to register our benefit on explicitly when we feel something, whether we feel it's better or worse for us. So utility has been a measure that's been tried to be captured around economics for quite some time, and more latterly in the last couple of decades in health economics. It's now been brought down to a fairly straightforward set of values that we can use to impute the change in quality of life. So if our quality of life improves from being fairly sick to being almost back to normal, we can say that there's been a numeric change in our utility from, say, 0.5 to 0.9, where 1 would be perfect health. So we've gone from 0.5 to 0.9, or 0.4 incremental gain in utility. Those then are put into then multiplied by how long you get that utility for. So in some cases it might be a utility gain of a few months in cases of patients perhaps with limiting life-threatening conditions. For others, it could be a utility that goes on for the rest of their lives, and they're still 25 or younger. So you then have to measure. You have to then multiply it by the number of years in which that utility would apply to get the QALY. Whether it's a good measure or not is very debatable amongst not only economists but people in the health system as well, as I'm sure Mike will tell you. But at the moment, it's kind of the best tool we have that allows us to compare apples and pears across different health conditions. It's not perfect. No one would claim it is perfect, but at the moment, it's probably the best we've got.
The difficulty comes in that it is an abstract, more academic way of putting everything down to the same unit of value, rather than having a basket of things that you've counted, some top up, some top down, some saving, some different ways. So, and I think when you're talking to patients or clinicians or even the finance director and you talk the language of qualities, it's a bit abstract and it's a bit hard to grasp. So I think generally speaking, although NICE need to do it for that level of scientific rigour, I don't think it's something that the Health Foundation are expecting, unless somebody feels that you know, the health economist that they've already got in their project, and that's the way that they determined that they want to do it, and you can afford it.
Yeah.
Yeah, I mean, I would just add to that no one's expecting a full-blown cost-utility analysis or cost-effectiveness analysis to be undertaken, as I understand it.
Yeah.
That's a choice that could be made. It is not necessarily going to change the decision because, as Mike said, cost utility is a very narrow band, applies to a very narrow band of decision makers. Most decision makers want to know about a lot of other messy stuff as well, but it can help in the decision making process, particularly if you're not making a particularly good gain in outcome for the money you're expending. So if it's extremely expensive in order to produce that one extra quality adjusted life year, which is what the quality stands for, should have mentioned, then you might think twice. Well, is this really going to be worth it?
And there's a question kind of linked to that that's just come in. So someone's asking about how it's so difficult to put a value on improved patient experience. Do you have any advice to people on kind of a quick and easy tool that they could use to put a price on a patient-reported outcome?
Well, that's again a new and an evolving area in health economics, and people are beginning to look at what influences people's subjective valuation of benefit, and it's not always about the outcome. You can have some very good outcome, but the process of getting there is appalling. And so people are concerned about the process as well as the outcome of healthcare. No one wants to be, made to feel very uncomfortable or in great pain. Obviously, sometimes that has to happen in order to achieve an outcome. So, what is now being looked at is disentangling and trying to impute a price, a willingness to pay price. For these different facets of a treatment, but I don't really think that would be necessary for this type of exercise. It's much more of an academic exercise. Willingness to pay is still very experimental and very hard to conduct, even in under controlled conditions. But it's certainly something to think about.
Great.
Yeah, I can't add to that. Thank you.
So we have a kind of a specific question coming in now from someone who's working in an MDT service looking at the assessment of people with advanced Parkinson's. And they ask, we're using a mixture of patient satisfaction outcomes and profession-specific outcome measures. How much value have these in a final cost evaluation?
It's difficult. Yeah, I mean, difficult to know without knowing the specific measures. So.
Yeah, I mean, they in themselves, I think people, when they're considering benefits, I think it's better to consider them as a separate item, as a separate exercise to the costs. Now, you could say that some of the benefits or disbenefits are a cost, if you like, and you can interpret costs and benefits either side of the equation. But for my mind, it's simpler to keep the aspects of patient satisfaction outcomes all to on the benefit side of the equation, and leave the cost to the kind of things I've been explaining just earlier on, that are simply hard and fast resource uses. So there may be an interaction between between a cost and a benefit, but I would say don't muddle them up. Keep them separate and then bring them together at the end, and we can do a session on economic evaluation at a later stage, perhaps.
Great, thank you. Another kind of specific question. Someone's asking about their project is going to probably ensure that fewer people get lost in the system. And so it potentially means that the caseload of their particular service will be increased. That's going to be offset any savings per patient. Do you have any advice on how you could convince a finance director or a manager or a decision maker that that is worthwhile?
Can I start
Yes.
that one?
Whilst I think about it.
Generally speaking, and I don't know the specifics of this case, but patient lost to follow-up, presumably you're treating that patient for something. So let's say I'm being treated for diabetes or a more serious thyroid disorder. I get lost to follow-up. I default from my treatment. I don't have my investigations. I stop taking my medicine. I'm going to reappear in A&E or in the acute system. Now, a follow-up appointment will cost X, and an A&E assessment or an emergency procedure or an emergency admission will cost 5 times, sometimes 10 times. Patient will get re-referred to the more costly ends of the system. I think within this question lies, some of the dissatisfaction with the way that some parts of NHS management have gone in terms of they're maybe not clinicians sometimes, and they may not understand the actuality of what it is you do and the real benefits. So,
and who are the best people to engage in that scenario?
Well, one of the things that we're going to be doing later on this week is seeing some of the patients telling their own stories about how and first-person narrative from patients saying how this innovation has changed my life, and how I've seen patient testimony from a perinatal project where they've reduced stillbirths from 6 in 1 year to 0 in the following year. And you only need one patient to say, actually, my first child was stillborn when I had suboptimal care, and now my second child is 3 years old and doing wonderfully. And that's what I call the kind of Bob Geldof moral argument of this is why we're doing it. This is why we're doing it. You have to do this. How can you be so heartless?
Just bringing it back to the economics, I mean, you just you touched on the fact that those other bigger savings that can be made. As I said early in my talk, those are things that you need to net off against the cost of the project. So presumably, if you can identify how many patients will go on with complications or will have a more advanced disease by the time that they do present themselves, then you could then bring those savings into your cost. I mean, a lot of people think that by doing providing a good service, they're going to actually reduce costs. But in fact, it's often the case that by doing the right thing and by doing it to the right standard, that you're actually going to initially increase costs. You're going to be finding more patients, you're going to be treating them more thoroughly, you're going to be following them up more appropriately. That does all increase costs, but what it does do is to prevent some of these downstream costs.
Brilliant. I think we have just one final question for you now. It's a project team who've told us that they were originally planning to introduce a new pathway all in one go. Things have changed. It's now going to be more of a staged introduction. They're wondering whether they should hold off their financial data collection until the pathway is up and running in its entirety, or whether they should do it before then.
I mean, this is what we often talk about in terms of PDSA cycles, and it's entirely appropriate in doing something new that you test things out small scale, you do a little pilot, and you work your way through. So I think this is fairly typical, and in the most pragmatic way, I think collect your data as you go along, and probably decide at the end whether you want to take that period because it's representative, or aggregate the whole lot into one. And then basically, as you do with any research study, at the end you say, well, these were the limitations. And I think it's entirely appropriate. We went through a number of PDSA cycles. we first did this, then we spread it out to another ward, which maybe was slightly different patient characteristics, and therefore we've got another confounder in that. It was over this time period. Things changed during that time period. You know, I had a project that's just finished. They opened up an entirely new hospital in the middle of the project somewhere up the road, and half the staff disappeared. So all of these things will happen in real world observational evaluation, and it's fine. It sometimes it just has to be a bit dirty, and that's okay.
Yeah, no, I absolutely concur with that. I think the sooner you can get your data collection systems and your costing systems in place and start to collect real data, whether it's the run-in periods I mentioned or whether it's the actual period you're going to use, you're testing out your methods, you're testing out your survey instruments, you're testing out whether data collection systems will actually hang together and work. It's important to do that. But as Mike says, pick a period where you know that it's a stable period for the project, and it looks like how it would work in longer term practice.
And hopefully you've got a baseline that is in the same seasonal
slot,
there's
potentially. There's always
yeah.
the baseline comparison.
Yeah.
I had mentioned that in my talk. You need to pick a comparable, typical period which doesn't have any particular peaks or troughs. Mm-hmm. Yeah.
Great. Well, I think that's just about all we've got time for. So thank you to Rick and thank you to Mike. And thank you to everyone else for joining us today and for all the brilliant questions you've sent through to us. If there's any that we haven't answered, we'll be answering them after the broadcast. So you can actually continue to submit any if anything comes to mind in the next few minutes. We're also just going to send out a very, very brief survey in the next couple of days that allow you to just tell us how you found the webinar. And you can also vote on what we cover next. This is the first of a series of about 8 webinars taking place over the next couple of years. Thank you all very much.